We will now start the second session, okay? It is a great pleasure to be with the eminent members of the EASD. My name is Professor Omar Sadani from Cairo University. The first speaker here will be Professor Mina. She will speak about hypoglycemic mechanisms and possibilities for prevention. And how can I prevent this hypoglycemia? Professor Mina is, of course, an eminent doctor from Greece, and she has special interests in diabetes and hypoglycemia.
Good afternoon, everybody. Thank you very much for the nice introduction, and thank you for the great hospitality and the excellent program that you have put together. Actually, my name is Mina Mitrakou. Mina is my first name, but it's nice. That shows that we are close friends. So my talk today is hypoglycemia, mechanisms and possibilities for prevention. As you all know, the brain is a very delicate organ that depends only on glucose in the circulation, cannot create glucose and cannot store glucose, so we have to be sure that the glucose levels are correct in the blood. And there are two sets of hormones that take care of that, insulin and the others. And when I say the others, I mean the counter-regulatory hormones, which are cortisol, norepinephrine, epinephrine, and growth hormone. Usually, we see hypoglycemia in the people we treat with insulin or any secretagogues because we leave them in many hours in hyperinsulinemia during the day due to the deficiency of the pharmacokinetics of the insulins that we were using up to now. What happens in a normal person, there is a hierarchy of responses in order to keep the blood glucose in normal values after the blood glucose is trying to fall below 70. And this hierarchy means that at levels around 60 to 68 to 69, when the glucose falls at that level, then you have the secretion of counter-regulatory hormones. Right after that, around the level of 60, you have the adrenergic symptoms, which are tremor, palpitations, anxiety, sweating, and these are the symptoms that tell you that your blood glucose is falling, so you have to do something not to let it fall any further. But if it does, then you get the neuroglycopenic symptoms around the level of 50 milligrams per DL, which means that your brain understands now that the blood glucose levels in the periphery are low. And if nothing happens there, if you don't take any precautions, then hypoglycemia evolves, and then you have levels of 40 and 30 and 20, and if they are for a long time, you may go to lethargy, coma, or convulsions. This thermometer was taken from these elegant studies we did back in Mayo Clinic with Professor Garrick and other colleagues, where we brought normal people in the laboratory and we brought their blood glucose levels down from euglycemia 90 to 78, 65, 54, and 45, and as you see at the scale over there. Bringing down the blood glucose levels gradually, we would leave the people around 40 minutes at each level, because it takes about 20 to 25 minutes for the brain to understand the level of glucose in the periphery. And we were measuring hormones and symptoms and cognitive function. And this is how we saw that everything changes at a certain level. Actually, as you see at the bottom of the slide on your right-hand side, you see that even cognition changes during hypoglycemia at a level around 45 to 50 in normal people. Moreover, following the same design of studies, other people have looked at prior hypoglycemia in normal people. So if you create a hypoglycemic episode of around 60 milligrams per DL in a normal person, and you study him the next day with the design I showed you before, you see that they have decreased secretion of glucagon and epinephrine hormones, and they have less symptoms of hypoglycemia. And as our population grows older and our type 2 patients are older, we have to take care of what happens in older people. And in older people, normal people, you see a decrease of the symptoms during hypoglycemia, and actually they happen at a lower level. And not only that, these people get disturbances of cognition, so it takes them longer, as you see in the blue, to achieve the cognitive test than younger people. What happens in type 1 diabetes? Well, we treat diabetes type 1 intensively in order to avoid the complications of diabetes, but this has a result, a threefold increase of hypoglycemia in the intensively treated group. And let's see what happens in terms of physiology in people with type 1 diabetes. Early on, upon the diagnosis of diabetes, if you do an acute hypoglycemia in these people, they have the release of all the hormones, glucagon, adrenaline, noradrenaline, and cortisol. They don't have glucagon responses, right from the very first day of their diagnosis. And as the years go by, well, they lose the glucagon and half of the epinephrine in the beginning, but after 20 years of disease, they lose their epinephrine responses. So that makes it hard for them, if they don't have glucagon and epinephrine, if they get a hypoglycemic episode, to come back to euglycemia. Along the treatment of diabetes, along their life, you see that many patients with diabetes lose their adrenergic responses. So we have people who understand their hypoglycemia and people who do not feel their hypoglycemia. And if you study them with the same design, you find out that the people who do not understand their hypoglycemia, they have decreased norepinephrine and epinephrine responses, and of course they don't have glucagon from the beginning. So the thermometer becomes like that. You have everything moved down, which means that you get first the neuroglycopenic symptoms a little in a lower level than in a normal person. You get the adrenergic symptoms in a very, very lower level, almost at the same level that you got the cognitive dysfunction. And of course, you have decreased counterregulatory hormones, both in magnitude and at the level of glucose where they are secreted. And this phenomenon is related to diabetes relation and intensified control of diabetes. So putting it all together, you see that the intensive insulin therapy in people with type 1 diabetes, just because they have imperfect insulin substitution, we have a strict goal of normoglycemia, and they have deficient glucagon responses to hypoglycemia. That leads to mild recurrent hypoglycemia of levels around 60, which then impairs the secretion of adrenaline, and that leads to severe hypoglycemia, but also it leads to initial loss of symptoms, which is hypoglycemia and awareness. And if you don't understand your hypoglycemia, then you get more hypoglycemic episodes, and it's a vicious cycle that leads to severe hypoglycemia. Is the phenomenon reversible? Early on, we studied this phenomenon, and we found that in people with insulinoma that are completely unaware, if you remove the insulinoma, then even within 1 week, they have complete restoration of their symptoms and the secretion of the hormones. The same phenomenon was studied in people with type 1 diabetes. This group took patients with type 1 diabetes who were unaware. They followed them up, relaxing their control without altering their hemoglobin A1C, but even if they alter it, it doesn't really matter for a short period of time. And they could see that even within 1 week, but of course most expressively within 1 month, they had the restoration of their symptoms and their epinephrine responses. Of course, they cannot regain their glucagon responses. Because of normal physiology and because of physiology in diabetes, the classification of hypoglycemia according to the new guidelines this year comes like this, that a level of below 70, just because of all this physiology, is a glucose alert value. You may treat it until it becomes 80, or this is a good value for adjustment of your anti-diabetic regimen. So it's an alert. But what is really clinically significant hypoglycemia is the level below 54 milligram per dl. Then you have to treat 15 grams of carbohydrates, wait for 15 minutes, another 15 till you reach the level of 80, and then eat your proper food. And then you have severe hypoglycemia, where you don't have any specific glucose thresholds, and it's the hypoglycemia associated with severe cognitive impairment, require external assistance for recovery. And now I come to type 2 diabetes. Type 2 diabetes, upon its diagnosis, is super normal. The big circle on top is the overproduction of catecholamines during hypoglycemia in a person with type 2 diabetes compared to a control. But as you treat them intensively and you bring them back to a normal hemoglobin A1C, they reduce their catecholamine and glucagon responses, and they become like the normal people. They are still not deficient, so don't be afraid of them. But if you treat them with insulin for a long time, then, as you see on top, they start diminishing their glucagon responses, and they diminish their epinephrine responses, and of course their symptoms of hypoglycemia. So if you take them all together, a person with type 2 diabetes more than 2 years on insulin treatment starts resembling with a type 1 diabetic at the diagnosis of its disease. But then we have to treat our type 2 diabetics intensively, because we have seen in most of the studies that we decrease microangiopathy. And that has a result, of course, an increase of all episodes of hypoglycemia, and moreover, an increase of severe hypoglycemia in these people. And as in type 1, even in type 2, the duration of diabetes is related to the severe episodes, severe hypoglycemia occurrence. Hypoglycemia is more often seen in people with sulfonylurea compared with other medications, but mostly on insulin compared to sulfonylurea. And among the anti-diabetic treatments, of course, you see more hypoglycemia in the people treated with sulfonylurea compared with all the other drugs. As for the insulins, the insulin treatment of diabetes, especially the type 2 diabetes, you see more hypoglycemia events in the people who with the pre-meal insulins only compared to the mixtures or the basal bolus insulin. But what lessons have we learned about hypo in people with type 2 diabetes? These are lessons that we learned from 24,000 patients on the intensive treatment studies. In all intensively treated studies, VADD, Accord, Advance, the intensive control was accompanied with an increase of severe hypoglycemia. Most importantly, what we learned from the Accord study is that those who are not well controlled and they are difficult to bring them down in good control are the ones who have more severe hypoglycemia episodes. Severe hypoglycemia is related to the duration of insulin treatment, the low GFR, the low estimated glomerular filtration rate, peripheral neuropathy, education beyond primary level, and the past severe hypoglycemia. Lower fasting serum glucose and higher glucose-related hemoglobin are significantly associated with the frequency. And of course, we have a U-shaped curve on our hemoglobin A1C in order to see if the person will have a severe hypoglycemia. So the difficult parts are the very high hemoglobin A1C and the very low, because they seem to have more hypoglycemic events. What are the consequences of severe hypoglycemia? They are both from the heart and the brain. In terms of the heart, they increase the risk of arrhythmias. They are accompanied by abnormal prolonged cardiac repolarization, and they lead to sudden death. In terms of progressing neuroglycopenia in the brain, they are accompanied with cognitive impairment, unusual behavior, seizures, coma, and brain death. This is an acute hypoglycemic study done in a person with type 2 diabetes, and you can see the prolongation of the QT interval in this hypoglycemia study. And these are studies where they measured autonomic cardiovascular function by baroreflex sensitivity, and you see that it is abnormal during a hypoglycemic event. The way hypoglycemia leads to these events is either through autonomic neuropathy and then CNS activation, high risk of arrhythmias and sudden death, or through autonomic neuropathy, hypoglycemia unawareness, more episodes of hypoglycemia, QT prolongation, arrhythmias, death, or don't forget the potassium levels, because hypoglycemia is accompanied by low potassium levels that may lead to arrhythmias and death. Moreover, the counterregulatory hormones secreted during hypoglycemia are the ones that may have an impact, a negative impact on the progress of myocardial ischemia, because epinephrines are the ones that may increase hematocrit and platelets. Then cortisol is the one that increases the leukocytes, and they have a negative impact on myocardial infarction. Severe hypoglycemia, as we have seen in the studies, is accompanied by high mortality. And does it impair cognitive function? It doesn't seem to impair cognitive function in people who have normal cognitive function. But be careful, the people who have cognitive impairment before you start an intensive treatment, they are the ones that you shouldn't start an intensive treatment, because you should be afraid of hypoglycemia, because then it will be even worse and they may even lead to dementia. And this is why the lessons we learned from all the studies led ADA and EASD to talk about personalization of insulin treatment, and you have to take in account when you see a patient, you have to take in account whether he has many hypoglycemias or not, so to relax his treatment. What do you do to prevent hypoglycemia? In terms of oral anti-diabetic treatments, prefer the DPP-4 inhibitors, the GLP analogs, the SGLT2 inhibitors, and the metformin versus sulfonylureas. And these are studies that were done with the same design that I showed you on the first slide. GLP was introduced in these people, and you see the people who got the GLP sub-Q, they had greater glucagon responses during hypoglycemia. And these are studies done after an oral glucose tolerance test. So a DPP-4 inhibitor suppressed glucagon during the OGTT, but then it increased the glucagon during hypoglycemia. And here you see that you don't see any severe hypoglycemia episodes when you combine insulin with the DPP-4 inhibitors. As for the insulin treatment, prefer the basal insulins along with GLP, or the basal bolus treatment, and not the premixed insulins. Among the insulins that we have available, prefer the analogs, because all the studies, the meta-analysis of the studies have shown that the analogs, both short-acting and basal insulins, are accompanied with less hypoglycemia. Actually, 30% lower hypoglycemia and nocturnal hypoglycemia with the basal analogs, and with the short-acting, you have 40% reduction of nocturnal hypoglycemia. In terms of mode of treatment, of course, the pumps are doing better than the multiple insulin injections. And we have to consider the continuous glucose monitoring, because the continuous glucose monitoring brings warnings of hypoglycemia, prediction of hypoglycemia, and it's accompanied by automated insulin delivery. And these are the personal CGMs that the people wear, and they can read and see their blood glucose values every 5 minutes. They have trends and graphs and arrows and alerts. So they alert the person about the coming hypoglycemia, and they offer education and motivation to the patient. Using the CGM in people with multiple insulin injections or insulin pumps has helped to not only to decrease hemoglobin A1C, but also to reduce severe hypoglycemia over a period of 1 year. While using the continuous glucose monitoring along with the new pumps, you have safety overnight because the automatic suspension of the insulin delivery at a level that you have already set to the pump stop at the 70. That means that the pump stops at the 70 milligram per DL, stops for 2 hours, and then restores insulin from the pump after 2 hours if the blood glucose is normal. If not, it remains stopped for a longer time. Using these pumps, we have seen 30% lower number of events of hypoglycemia, 40% lower severity and duration of nocturnal events, and most importantly, 0 severe hypoglycemia and 60% lower nocturnal time in hypo. And the latest model available, I don't know if it is available in your country, is the prediction low glucose pump, where this is magic. I mean, it's the first step before the artificial pancreas. The pump stops infusing insulin when there is a trend of the blood glucose to fall from 150 milligram per DL to 70 milligram per DL within 30 minutes, and then restores insulin secretion. But don't forget education. You cannot do much with technology if you're not using education. And actually, the UK Daphne experience is great, and I would tell you, go to the internet and find the educational program, because 5 days course for patients with hemoglobin A1C around 7.5, in a 1-year follow-up, had a result of restoration of hypoawareness at a level of above 58 in 43% of the patients, and avoidance of severe hypoglycemia in 30% of the patients. What you can do in your practice, you have to identify the persons with hypoawareness. And you can do it very easily with the history of hypoglycemia when they come to your office. Ask them how often they have hypoglycemia, if they get nocturnal hypoglycemia, how many episodes of severe hypoglycemia, if they're aware or unaware. Check their symptoms. Ask them about exercise, alcohol, and insulin doses. Ask them about how often they monitor their blood glucose levels, and also find out from their history if there are factors leading to severe hypoglycemia. I mean, if they're old, or if they have long diabetes duration, if they have renal impairment, or if they have lost weight during the last period. And I would advise you to offer even these simple questionnaires, the Clark and Gold questionnaire, that you can have it in your office, and if you get a result of over 4, that means that your persons are unaware, and this is how we found out that 25% of our people with diabetes, type 1 diabetes, have hypoglycemia and awareness. So it's education, technology, and last comes transplantation. Actually, transplantation is the only indication for transplantation for people with diabetes is when they get many episodes of severe hypoglycemia, and actually it is restored. And don't forget that technology has come to a point that the first artificial hybrid artificial pancreas got approved by the FDA September of 2016, just by the safety study where there was no hypoglycemia and no severe hypoglycemia observed and no ketoacidosis. Up to the day that we'll have the artificial pancreas available in our hands for everyday use, then we should go slowly through the algorithm that Pratik Chaudhary, who is coming to give a talk tomorrow, has proposed. So if you have patients with more than 2 episodes of severe hypoglycemia or a Clark score above 4, then the first thing is educate them and start them with analogs. The BGAT is an educational program that he proposes. If they still have hypoglycemia and more episodes of severe hypoglycemia, put them on a pump with a real-time CGM. And if that's not efficient, then the last step will be to put him on a pump with predictive low glucose levels. But don't forget, educational programs should be aside at any moment. So that is my conclusion for how to treat and prevent hypoglycemia and severe hypoglycemia, and be cautious about any blood glucose levels around 60 milligrams per dl. Thank you.
Thank you very much for your very elegant, and you are just on time. Thank you.
For more questions? Okay, Dr. Didac Mauricio from Greece. Treatment of dyslipidemia goals, and from Spain, sorry.
It's okay.
Treatment of dyslipidemia goals in diabetic patients.
Okay, thank you very much. I am really grateful to be here, and I thank the organizers for inviting me to be in this unique city and country. This is my first time, so I may have time to visit the city and probably the pyramids. Yes, I'm from Spain, but I could be from Greece or from any part of the Mediterranean, as you see. I'm from Barcelona. We won't talk about politics today, I guess. So I'll try to keep on time also. So I'm going to just give a short overview. We could talk about lipid treatment in diabetes for a whole symposium. So it's not my objective to have a thorough review of what's treatment of dyslipidemia in diabetes. These are my disclosures, and this is the outline of my talk. So I just chose some things that I thought it could be interesting for you, and maybe for some questions at the end of this session. So first of all, I want to insist on when we talk to young physicians about goals, we shouldn't forget that LDL or HbA1c are not really the primary goals of diabetes treatment. We shouldn't forget that our aim is to give all the time we can to our patients, and also all the quality of life that we can give to them. So this is very important, and we should keep that in mind when we treat patients, because LDL or HbA1c or whatever are just surrogate endpoints of treatment. So to prevent morbidity and mortality and loss of quality of life in diabetes, we use these surrogate endpoints, such as HbA1c and all the cardiovascular risk factors. So please keep always that in mind. And this is the outline of my talk on Saturday. And Leszek was so kind that I will be talking about blood lowering today, lipid lowering today, and he will be talking about blood pressure lowering. So I will save this from my talk on Saturday, okay? And as you know, cardiovascular risk is especially high in patients with diabetes, and that's the case for all the events. As you see, all of them, stroke or cerebrovascular or coronary heart disease are increased, but especially peripheral vascular disease, okay? But this is also the case in type 1 diabetes, which does not have this aggregate of factors associated with increased cardiovascular risk. I mean, type 1 diabetic patients have increased cardiovascular risk, and this is just because of glycemic control and because of some of the complications. We would just have a touch on that on Saturday. And as you see, type 1 diabetic patients are also at very high risk compared to the background population. This is a very well-known study on the Swedish registry, and they nicely showed that patients, even young patients, are at increased risk of cardiovascular risk. And this is especially the case for women. As you see, women are clearly at much higher risk when you compare them to the background population in relation to men. Okay, so this is very, very important. And we know that we should, why we treat these cardiovascular risk factors is because atherosclerotic disease is a process that takes years, and we are trying to prevent events, and once the event is there, we also try to prevent new events. Okay? So what are the goals of therapy? And then I decided just to choose a couple of guidelines. I chose the guidelines that the EASD participated in, which are the last year guidelines that were issued together with the European Society of Cardiology and many other societies. And for lipids, this is based on the consensus on lipid management that were published also by the same societies. But I also took the guidelines from the American Diabetes Association, because these guidelines are issued each year. So next year's guidelines will be issued very soon. They are usually issued late November or December. So we will have the next guidelines, and some of the issues will be probably changed. And which is the lipid target? The lipid target is usually LDL cholesterol, okay? And this, if you look at the guidelines of the European societies, you see that LDL is the target that we use to treat, to assess the risk, and to reach our objectives. And if you look at the risk, we will talk about that on Saturday, but most of our diabetic patients are either at very high cardiovascular risk or at high cardiovascular risk. Very few patients, mainly some type 1 diabetic patients, are at moderate risk. So our lipid goals are really usually around 100 milligrams or 70, depending on the risk or the background cardiovascular status of our patients. What about the ADA? They do not set LDL targets. They use the American way that was issued 3 years ago by the American College and American Heart Associations, and they just say that in adults that are not taking statins, we should assess lipid profile either when we visit them the first time or at diagnosis, and then every 5 years. Okay? And of course, if you are initiating therapy with statins, we should also obtain a lipid profile. Otherwise, we should go ahead with treatment. Okay? And of course, we may use lipid profiles because we want to assess whether the patient is adherent to treatment or whether we are reaching more or less intensity in our treatment. But my question is whether is LDL the right target in diabetes? And of course, if you go to the literature and see all the studies in secondary or primary prevention, and you look at the LDL levels, the lower the LDL, the higher the rate of prevention you get in terms of cardiovascular morbidity and mortality. Okay, so, and this is just for all the trials, but it's also the case for type 1 and type 2 diabetic patients, as you will see. And this is also the case not just for statins, which were the studies we got, but for other treatments. The lower the LDL you have, this is a meta-analysis, the more the preventative effect you get. Okay? So it seems that LDL is a good target, but if you go back to the European guidelines and you look at other potential targets, it seems that you shouldn't look at HDL. You should look at HDL because it gives you extra information on what's the risk of the patient, but it's not a target. We are not using any drugs because they raise HDL. They just using them because they lower LDL. Okay, but now it's increasingly popular that we could use non-HDL cholesterol. That's a target that we may alternatively use as a secondary endpoint. And it's also useful because it has, you can determine that in a non-fasting state, okay? Although we do not use that in the routine clinical practice, this is an alternative. And we will be talking about triglycerides at the end of the talk, okay? Additionally, LDL in type 2 diabetes, as has been shown in many studies, including the UKPDS, is the one single factor having the highest impact in terms of prevention, on top of blood pressure and, of course, over glycemic control. So in terms of cardiovascular morbidity and mortality, LDL lipid treatment is very important. So it seems that LDL is a good target, at least for the time being. And how do we lower LDL? I won't talk about lifestyle, not today, not on Saturday, because there are other talks talking on lifestyle, but lifestyle measures should be there for all the time we treat patients, and we tend to forget that, okay? So weight loss and qualitative and quantitative changes in diet of our patients are important, and also, of course, physical activity. If you go to the European guidelines and you see where are our patients, most of our patients are at high or very high risk. And as you will see, of course, if the LDL cholesterol of patients is below 100, it may be the case that we do not need to treat them with drugs, but once you progress to the right, drug treatment should be there, okay? So what is the drug of choice? And if I ask you whether statins are your first choice, I guess most of you would do that. But let's see what happens with LDL. If you look at the potency of, in terms of reduction of LDL of different drugs, you see that statins are really the drug of choice because they lower LDL cholesterol up to 50%, okay? Much more than other drugs, than other groups of drugs, like ezetimibe, which is a cholesterol absorption inhibitor. And they also have a nice potency in terms of triglyceride reducing potency, okay? So it seems that for the time being, statin is still the drug, the group of drugs of choice. And these are the available statins. I do not know whether you have all of them. In Egypt, I guess so. And if we calculate the potency of reduction, the introduction of this concept of intensity took place 3 years ago with the Americans, dividing this depending on the doses, and as you see, only 2 of the statins at these doses are really high intensity statins, and the rest are moderate or low intensity statins. It should be said here that according to the American Diabetes Association, we should only use high or moderate intensity therapy, statin therapy, okay? And these are the doses. So the Americans do not use LDL as a target. They just divide the risk this way, okay? They stratify people according to the age. And as you will see, most of the patients we see should be on statins, according to them. And many of them are on moderate or high intensity statins, okay? If you have very high risk or you have already cardiovascular disease, you should use a high intensity statin, either atorvastatin or rosuvastatin. And the European guidelines say more or less the same. They do not use the term high intensity. They just say, okay, LDL this is the target, depending on whether you are at high risk or very high risk, and you should use statins. Okay, so this is what the guidelines say. But do statins work in diabetes? Because you know that other drugs like aspirin do not work the same in atherosclerosis in diabetes. Even stenting do not work the same in diabetic patients and in non-diabetic. So it may be the case that statins do not work the same in diabetic patients. And if we look at this cholesterol treatment trialist collaboration, and we look at a meta-analysis that they already issued in 2008, you can see that diabetic patients benefit from statins in any of the events you are looking at, either coronary events, stroke, or any other. They behave the same, okay? So the benefit is proportional, although we know that diabetic patients have what we call residual risk, that it's on top of the background risk. And if you look as if patients are in primary or secondary prevention, yes, statins works the same, okay? And if you look at type 1 or type 2, although there were very few patients here, 600 type 1, it works as well in type 1 and in type 2 diabetes, okay? And statins work at any cholesterol level, either LDL or triglyceride. They work nicely at all levels of lipid profile. What about other treatments? And here I was wondering which term to use. I'm talking about alternative treatments or combination therapies, okay? And we have this cholesterol absorption inhibitors. We have ezetimibe. I guess you have this in Egypt, yes? And I'm not going into the IMPROVE-IT trial, which already showed that it could have an additional benefit on top of simvastatin, right? In terms of prevention in the trial of the primary outcome. And if you look at the results of the trial, you see that diabetic patients benefit even more from this treatment, from this combination, than patients without diabetes. So it seems that it may be useful. And what does the European guidelines say? Europeans say, okay, in case of intolerance to statins, you can use ezetimibe, okay? Or, the Americans do not mention that usually, or bile acid sequestrants, that is resins, okay? And if the goal you're aiming at is not reached, you may add also ezetimibe to statin, okay? Or a resin, though this is not very popular. What the Americans say about combination therapy is say, okay, ezetimibe has been shown in one trial to be effective on moderate intensity statins, so some of the patients may benefit from that, and especially those patients with acute coronary syndromes that are not reaching the 50 LDL cholesterol target, which is not included in the European guideline, okay? And of course, those at very high risk that cannot tolerate statins. And we have a new group. This is the name of an enzyme, proprotein convertase subtilisin kexin type 9, PCSK9 inhibitors. What happens with this enzyme? We are starting using these new drugs. This is a new drug in the class, and this is how it works. Okay, usually the hepatocyte produces LDL receptors and also produces this enzyme that is not active. This is secreted, and the enzyme is bound to the LDL receptor, then it is internalized. It undergoes, most of these bound molecules are then degraded, undergo degradation, so the LDL receptor does not recycle and go to the membrane anymore, right? This is the usual situation. What happens if I block the PCSK9 with an antibody? What happens is what you see in the lower panel of the figure, that is that the LDL receptor goes internalization and then goes back to the surface. So the final result is that you have much more receptors on the hepatocyte. Okay? This would be the summary. You have PCSK9 and you have the usual way, so LDL may be increased. If you block PCSK9, then you have much more receptors on the surface of the hepatocyte, and then you can absorb you can lower much more and internalize much more LDL cholesterol. It has other effects that are currently under investigation, because it not only lowers LDL cholesterol, it lowers many other, like LPA. That's the first drug that lowers LPA. Okay? And this is, if you look at the guidelines, the American and the European guidelines, they say, okay, it seems that these drugs lower cholesterol very effectively, because in this trial they could show that the placebo-treated group had a cholesterol of 90, and the PCSK9 group had a cholesterol of 30, LDL cholesterol of 30 milligram. And they nicely showed that they could reduce 15% the risk of the primary outcome, which was a 5-point outcome. And on the right panel, you have the classical MACE in the trials, which is cardiovascular death, non-fatal stroke, or non-fatal myocardial infarction, which was reduced by 20% on top of statin. We are now waiting for the results. This is for one of the antibodies. This is evolocumab, and very soon we will have the results of the Odyssey trial. This is the Fourier trial with evolocumab, and we will have the results of the Odyssey trial with alirocumab, and hopefully there will be a nice effect also in terms of prevention. So last year, the guidelines, before this trial was issued, the guidelines saying, okay, both the American and the European said, yes, okay, it seems that PCSK9 inhibitors may have an additional effect, but we should wait for trials. But now we have already one trial, so we are already starting using that. I don't know if that's the case in Egypt as well. We are starting using that in some with important restrictions, because these drugs are very expensive. So there are severe restrictions on the use. We're using that in patients with familial hypercholesterolemia, and in patients that do not respond or have intolerance to statins with cardiovascular disease. What about triglycerides? Who thinks that triglycerides are important? Yeah, some of us think that. But if we go to the classical, typical dyslipidemia that type 2 diabetic patients show, this is atherogenic dyslipidemia. And this is characterized by high triglycerides with increased or normal LDL, with low HDL cholesterol. And the problem with LDL is that the small, dense, highly atherogenic particles of LDL are increased in these subjects. And this is very important. We are not usually having triglycerides as a target, but if you have a perfect lipid profile and you add on that LDL higher triglycerides, you have much more risk, okay? That's what we call residual risk, because these patients are at high risk despite having optimal LDL. What do we use for triglycerides? Usually we use fibrates, and because they are together with omega-3, but especially they are potent in lowering triglycerides. And I guess you use fibrates. We do not use niacin because it was shown even to increase the risk of stroke in one of the trials. So the use of niacin is discouraged. What about fibrates? If you look at the trials, all the trials with fibrates were not able to show an effect in terms of cardiovascular outcomes. So the guidelines say, okay, we are not sure about their effect because they have not shown an effect. But my guess is that they did not choose the right patients. Because if you meta-analyze what has happened in those trials, and you look at patients having dyslipidemia, atherogenic dyslipidemia, it seems that it works in terms of prevention. So for patients with atherogenic dyslipidemia, it seems that fibrates should work, okay? So in the European guideline, they say, okay, you should use statins because they lower triglycerides, and that's the first choice. But if you have high cholesterol and you cannot control that, you may consider using fenofibrate in combination with a statin. You never use gemfibrozil because it's of the secondary effects, high risk of myopathy, okay, in combination with a statin. So that's what I was saying. What about the ADA? The ADA says, okay, statin fibrate is generally not recommended as a combination, okay, but you may consider that if you have this lipidemia, okay, and they do not recommend, of course, the combination of statin and niacin. So my conclusions are that LDL is the cornerstone of dyslipidemia treatment, also in diabetes. That it's very important, especially in diabetes. It's very important to assess the individual cardiovascular risk of the patient, and then you should that should lead to the decision on which is your LDL target and which is the magnitude of the LDL reduction that you need. At least when choosing the drug in terms of European way of thinking. Okay? Non-HDL cholesterol is potentially a secondary objective. Statins are the first choice. Statin intensity choice should be according to LDL target in Europe or any other parts, and to the reduction required in the States. And of course, we need to use the clinical judgment when we see a patient. That's the most difficult thing about diabetic patients. Each patient is a new thing. It's very difficult. You have to combine all the therapies. So we need the clinical judgment on whether we should use alternative treatment or additional therapies on top of statins. And please remember that patients with diabetes have atherogenic dyslipidemia, type 2 diabetes have atherogenic dyslipidemia, and that these patients may benefit from adding fibrates to the treatment. And as we will see in my talk on Saturday, the treatment should be multifactorial. Thank you very much.
Thank you,
I guess the
Dr.
questions-
Mauricio
Yeah.
from lovely Catalonia.
Yeah, thank you.
For your wonderful talk. Okay.
I guess the questions are at the end? Yes. Yeah, okay.
Yes, we would like to welcome Professor Dr. Dario Rahelic, who is going to talk about treatment of hyperglycemia.
Dear Chairman, dear ladies and gentlemen, it is my great pleasure to welcome you on behalf of Croatian Society for Diabetes and Metabolic Disorders, but also I would like to take opportunity to thank the organizing committee, especially my dear colleague and friend Professor Ines Schaltot, for inviting me for the second time here in Cairo, in beautiful city of Cairo. And this morning I had the pleasure to visit pyramids again, like 2 years ago. So, but in the next 3 hours, I will speak about the treatment of hyperglycemia. I'll try to do my best to do it in just 3 hours, because they asked me to do it in only 30 minutes. But 30 minutes is not enough to speak about hyperglycemia and how to treat hyperglycemia. So I focused only on one part of hyperglycemia. What is the most important when we target glucoregulation? So these are my disclosures. But I would like to focus on cardiovascular disease and hyperglycemia, and especially one part of hyperglycemia is glycemic variability. So diabetes is a cardiovascular disease, and cardiovascular disease is the leading cause of death in people with type 2 diabetes. You already know that people with diabetes will die from cardiovascular disease. More than 3/4 of them, or 2/3 of them, will die according to cardiovascular disease. On the other hand, if they have also renal disease, they will die even earlier. So they will die from renal disease 10 to 20% of them, and cerebrovascular disease for more than 15%. So one of four independent risk factors for myocardial infarction is diabetes. So diabetes at least doubles risk for diabetes. And what we know, that diabetes is associated with increased risk for myocardial infarction. And no matter, you can see it here, if somebody, so I will show you here, if somebody without diabetes had myocardial infarction, that person has increased risk for another myocardial infarction. Person with diabetes without prior myocardial infarction is at the same risk as somebody who already had myocardial infarction and doesn't have diabetes. So in Europe, we have more than 85 million people across Europe were living with cardiovascular disease in 2015, and we know that people with diabetes have 2 to 4 times are more likely to have stroke than people who don't have diabetes. So it's a dilemma. Should we treat diabetes in cardiovascular disease or cardiovascular disease in diabetes? Many landmark trials confirm that estimated 37% decrease in microvascular disease will happen with only 1% of decrease in HbA1c. So from that perspective, we have to think about it. And also, according to macrovascular complication, every 1% of HbA1c will decrease the risk of macrovascular disease for approximately 14%. So we do have lots of cardiovascular risk factors which are modifiable or are not. We can divide them to behavioral risk factors like diet, physical activity, smoking, alcohol use, but also medical risk factors like high systolic blood pressure, high total cholesterol, fasting plasma glucose, postprandial plasma glucose, but also high BMI. All of these factors are applicable to people with diabetes. Also, there is always a dilemma, what is more important? Is it more important LDL cholesterol or HDL cholesterol? Is there any importance in triglycerides level? But no matter, we know that there is many different factors which are involving in pathogenesis of cardiovascular disease in people with type 2 diabetes. From that perspective, we can argue what is the most important. Is it hyperinsulinemia? Is it hypertension, LDL cholesterol, hyperglycemia, fasting or postprandial hyperglycemia? Is it free fatty acid compoundings or dyslipidemia? Is it important to have procoagulate state? What about glycated proteins, advanced glycation end products? What about genetic predisposition? What about the epigenetics? What is the most important for cardiovascular disease development in people with type 2 diabetes? The another question is, how do we modify CV risk in type 2 diabetes? Is it lifestyle modification? Of course, we can do a lot from that perspective, but also glycemic control, blood pressure control, management of dyslipidemia, and also platelet inhibition. Here you can see the modifiable cardiovascular risk factors which are common in people with type 2 diabetes. It's hyperglycemia, hypertension, dyslipidemia, obesity. But also we can have, and there are many examples of pharmacological intervention, like dyslipidemia, hypertension, thrombosis, stroke, myocardial infarction, but we can argue what is the most important here. But in this topic I would like to cover the risk of high blood glucose level. In the next 1 hour I will speak about diabetes as a coronary heart disease risk. Many different trials confirmed that with a high blood glucose level it will increase the risk of cardiovascular disease. But unfortunately, diabetes-related cardiovascular risk complications have declined with better control and with improved care. But unfortunately, substantial burden remains here, and there is always some residual risk. We can argue what is why that risk still remains. Is it because of glucose? Is it because of lipid or blood pressure or some other risk factors? But we have to ask ourselves, what is our target? Target in diabetes is like playing with a 3D puzzle. We have to target HbA1c, of course. We have to target glycemia, but also we have to target lipid profile and blood pressure as well. When we talk about blood glucose or glucose control, we can speak about fasting plasma glucose, postprandial plasma glucose, HbA1c, or maybe some other. And we can ask ourselves, where is the role of glycemic variation? As you know, HbA1c is a gold standard for diagnosis of type 2 diabetes. On the other hand, HbA1c is a gold standard for estimation of blood glucose control, and also is a gold standard for prevention or prediction of risk of the chronic complications of type 2 diabetes. But HbA1c includes normoglycemia, fasting hyperglycemia, postprandial hyperglycemia, but also the episodes of hypoglycemia as well. And UKPDS, as one of the landmark trials, confirmed that the effect of management of blood glucose on microvascular complications are impressive. So for each reduction of only 1% of HbA1c, we can reduce the risk of macrovascular complication for 25%. Postprandial glycemia or hyperglycemia is the first recognized alteration in people with type 2 diabetes. On the other hand, postprandial hyperglycemia has the major impact on 24 hours glucose profile in people with type 2 diabetes as well. When we talk about postprandial excursions or postprandial hyperglycemia, we can ask ourselves, is it really important? it is important because every single postprandial excursion can cause glucose toxicity, acute hyperglycemic events, and also we can talk about prolonged hyperglycemia as its own term. Acute hyperglycemia will cause glomerular hyperfiltration and can increase risk of glomerular disease. On the other hand, only one acute hyperglycemic event can increase retinal perfusion with increased risk of bleeding in the eye, peripheral neuropathy and autonomic effects. But also prolonged hyperglycemia will cause long-term complications, will cause protein glycation, which is important also according to chronic complications, and also will cause hyperinsulinemia, and hyperinsulinemia is the risk factor for cardiovascular disease per se, and so it's also something what we don't need and don't want. Postprandial glucose and cardiovascular risk, its relationship is more than well documented. You can see that many clinical trials showed correlation between postprandial glucose and cardiovascular risk. Honolulu Heart Program, also Helsinki Policeman Study, Paris Prospective Study, but many other clinical trials also confirm the importance of postprandial glycemia or hyperglycemia and cardiovascular risk. On the other hand, some studies show that the postprandial glycemia is more important than the ratio between fasting plasma glucose and HbA1c for cardiovascular risk. Here are listed possible mechanisms by which hyperglycemia may contribute to macrovascular complications or macrovascular disease. Increased protein glycation, sorbital formation, postprandial hyperlipidemia, oxidative stress, coagulation activation, impaired nitric oxide dependent vasodilatation, activation of protein kinase A. But it seems that no matter which pathway we are talking about, it seems that oxidative stress plays the most important role in complications of type 2 diabetes. And of course, this oxidative stress has its own impact on LDL oxidation, impaired nitric oxide dependent vasomotion, coagulation activation, increased endothelial permeability, etc., etc. We know that there are many different markers of glycemic control, and it seems that glycemic variability becomes important risk factor and marker of glycemic control. You can see it here. We know that HbA1c is the traditional marker, and also many others which are alternative markers, but it seems that glycemic variability could be important also as a marker of glycemic control. But what glycemic variability means? This is glycemic variability or glycemic variation. Variability or exposure or swing of exposure or average swing. So this is glycemic variation or glycemic variability. Some people can have the same mean glucose value, but completely different fasting plasma glucose, different postprandial plasma glucose, and different glucose swings. On the other hand, some people can have the same fasting plasma glucose, almost the same postprandial peaks or postprandial glucose value. They can have the same mean glucose value, but different glucose swings. And it seems that those glucose swings could have important role in deterioration of HbA1c level. And you can see it here. All of these patients here, marked with different colors, they have the same HbA1c, 6.5. Look at their glycemic values during the day. Their glycemic variation is pretty high, and it's a mess. And fluctuation in blood glucose occur despite stable HbA1c. We can have people with stable HbA1c with pretty stable fasting plasma glucose or pretty stable postprandial, but with different swings, and they can have completely different glucose variability despite the same HbA1c level. We can ask ourselves why. Because glucose variability will include also hypoglycemic events, postprandial glucose excursions, but also minor fluctuation in blood glucose levels. And it's not a new thing. It's a not new kid on the block. The first publications were already published almost 15 years before I was born. And today I'm talking about glycemic variation or glycemic variability as a new term, as an important term in glycemic regulation. But there is very good and very nice and elegant review which was published by Professor Weber, who is not a physician, and Professor Schnell, who is a physician, about glycemic variability, and they mentioned how to measure glycemic variability. And there are many different measures of glycemic variability, but two of them are the most important. It's standard deviation of mean glucose, and you can find it in any single glucometer, novel glucometer on the market. And on the other hand, the MAGE, like you can see it here, it's a gold standard for measurement of glycemic variability. We can argue what is more important, within day variability or day-to-day variability. We know that even in the same person, we cannot have the whole day glucose variation in very low profile, and also we cannot have the same glucose variability day-to-day in the same patients. So we can say that glucose variability can manifest as both within day variability and day-to-day variability. Today we know that mortality is connected or correlated with hypoglycemia. And mortality rate increase with the occurrence of severe hypoglycemia. And you still remember before 2008, all of us, we tried to reduce glycemia and to reduce HbA1c level to all of our people with diabetes to lower as we can or as we could. And for everybody we said the target is HbA1c below 6.5. Today we know that it's not like this. After the publication of our core trial, we have learned that people with very low HbA1c had increased mortality according to high risk of hyperglycemia and high incidence of hypoglycemia. So from that perspective, we have learned that the hypoglycemia and severe hypoglycemia can impact significantly on cardiovascular outcomes and also on mortality. Advanced trial confirmed that variability in HbA1c and fasting plasma glucose can predict adverse events, no matter in macro and microvascular complications. It seems that variability in plasma glucose is independent risk factor in mortality, and you can see it here. Of course, there are many different arguments. Can we confirm in type 1 and type 2 diabetic patients? But there is no doubt that diabetes and hypoglycemia goes together, and that hypoglycemia can increase risk of cardiovascular disease and cardiovascular outcomes and mortality in people with diabetes. When we talk about glycemic variability, it seems that the hospital mortality is related to glycemic variability in non-diabetic patients who were admitted to ICU, but not to diabetic patients. So from that perspective, we have many different contra-arguments to say that glycemic variability is important as a measure of glycemic control. On the other side, we know that glycemic variability and risk of hypoglycemia are well documented, and you can see it here. If we have if this is average fasting plasma glucose, we have different glucose swings during the day, and you can see it here. And occasionally we have episodes of hypoglycemia. But if our goal is to decrease the level of average plasma glucose or fasting plasma glucose, we will have the same swings, but look at what happened with episodes of hypoglycemia. Our treatment increased the risk and increased the number of episodes of hypoglycemia. So from that perspective, we didn't help to that patient. Also, but reducing average glycemia in people with reduced variability. What happens? If we have very low glucose variability and pretty high average fasting plasma glucose, even if we will decrease that, we will not be in the zone of hypoglycemia. Glucose variability predicts hypoglycemia during insulin treatment, and you can see it here. Intraday and interday glucose variability can predict hypoglycemia, but it seems that fasting plasma glucose variability can be also very important to predict hypoglycemia. And principal causes of blood glucose variability in diabetes are listed here. It's physiological or anatomic factors. It can be insulin administration. It can be properties of insulin products. On the other hand, the impact of half-life of insulin on insulin fluctuation can be important. And we know that new or novel insulin treatment can reduce the risk of hospitalization, can reduce risk of hypoglycemia, but also can reduce glucose variability. It seems that fasting plasma glucose variability is a useful marker of nocturnal hypoglycemia. And you can see it here that a correlation between change in fasting plasma glucose variability and change in nocturnal hypoglycemia in both type 1 and type 2 diabetic patients are more than obvious. Risk of severe hypoglycemia increases with the increasing glucose variability in type 1 diabetes, but also in type 2 diabetic patients. So we can ask ourselves, is glucose variability really matter? Does it really matter? It seems that glucose variability is an important predictor of severe hypoglycemia, and we can say yes, it does. It does because the frequency of severe hypoglycemia in insulin-dependent diabetic patients, or people who are with type 1 or type 2 diabetic patients on insulin, can be predicted from self-monitoring blood glucose data, but also on CGM data as well. So, to conclude regarding glucose variability, is glucose variability associated with mortality? It seems the answer is we don't know. Is glucose variability associated with complications? Probably yes, but there are conflicting results of published trial. Hospital admissions, we don't know. Costs, also we don't know. Quality of life, maybe, but also conflicting data. Increase oxidative stress, yes, correct, but only in type 1 diabetic patients. Only in type 2 diabetic patients, not type 1. Inflammation increased? Yes, it does. So from that perspective, I cannot argue, is it important or is it more important to target fasting plasma glucose or postprandial plasma glucose. Even Professor Riedel and Professor Monnier, they are still arguing what is more important. There is also a question: is it important to target only 2 hours postprandial plasma glucose, or maybe even 1 hour postprandial plasma glucose? So from that perspective, we really don't know what is the most important. But we know that hypoglycemia can cause damage to our people with diabetes. And only one episode of hypoglycemia can cause sudden death, myocardial infarction, and stroke. So the imperative for treatment of hyperglycemia is to avoid hypoglycemia. From that perspective, glucose variability, especially the variability of fasting plasma glucose, could be important. And when we talk about cardiovascular risks, when we talk about glycemia, we can argue that fasting plasma glucose is the most important. We can argue that postprandial plasma glucose is even more important. We can argue that glucose variability is not so important, or HbA1c, or some other markers of glucose variation or glucose control. We can argue about it. But no matter about what we are arguing, we know that we have to target them all. We have to target fasting plasma glucose, postprandial plasma glucose. We have to lower HbA1c as low as we can without hypoglycemia. We have to decrease glucose variability, especially fasting plasma glucose variability, because it's a marker of nocturnal hypoglycemia. And you know that as a physicians, for us is the most important primum non nocere. From that perspective, the most important thing is to avoid hypoglycemia and to target all markers of glycemic control, because our goal is to have people with diabetes with good quality of life, and especially without hypoglycemia, without cardiovascular disease, because our goal is to have them alive as long as we can, but without decreased quality of life. Thank you very much.
Many thanks, Dr. Dario.
Thank you very much for your very, very, very elegant lecture. It is a pleasure for me to introduce Professor Andrew Bolton from United Kingdom. Treatment of diabetic foot. Diabetic foot is a big, big, big problem in our country.
Thank you very much. As you rightly say, the diabetic foot in this region is extremely prevalent, and most of the cases that I see in the Middle East region tend to be neuropathic in etiology. So let me start with a quote from Voltaire. And Voltaire wrote these words. He said that the art of medicine consists of amusing the patient while nature cures the disease. Now, that may be true for some diseases, but certainly not for diabetes, and certainly not for the diabetic foot. And this is a lady that I met when I first arrived to Manchester as a physician consultant some 31 years ago. And clinical observation teaches us a lot. On this pointer doesn't work, so I can't point, but she can't focus very well because she's blind because of type 1 diabetes and diabetic retinopathy. There's a patch just to the right hand above her 90 there for the delivery of nitrates for her ischemic heart disease. She's got a scar in the center from a coronary artery bypass graft. She's just started peritoneal dialysis. This is 31 years ago. And she's got no legs. And she's 45 years old. Now, as I told you this morning, or earlier today in the first lecture, the outlook for patients such as this is worse than almost every form of cancer. 75% of people like this are dead within 2 years. So we have to take diabetes seriously. And she said to me, take this picture, because I don't want other people to end up like me. Can you do something to prevent the terrible late complications of diabetes? So what we're talking about is preventing amputations in diabetes, if at all possible. Let me give you some stark figures just published this year from the United Kingdom. £1 in every 140 of total National Health Service expenditure is spent on the diabetic foot. £1 in every 140 on the diabetic foot. Foot ulceration and amputation cost the National Health Service more than £1 billion. Multiply that by 25 for Egyptian pounds. And 2/3 of this sums is for treating foot ulcers in primary care and outpatient settings. So, where have we been successful and where do we have to do more? Well, we do know the causes of foot ulceration, and these come from good, properly conducted prospective observational studies. And we know that people in each of these groups is at increased risk of foot ulceration. Those with neuropathy, those with peripheral vascular disease, most at risk of all are those with a past history of foot ulcers or who've already had an amputation. Even in the best centres, if you've had a neuropathic foot ulcer, you've got a 30 to 50% chance every year of having another one. Very bad. If you've got microvascular complications, especially diabetic nephropathy, and I'll refer to this in my talk on nephropathy tomorrow, poor glycemic control, smoking, foot deformities, and, as I've said, amputation. Now, it was Dr. Paul Brand who worked in southeast India in Tamil Nadu, who I was fortunate to know. I first met him in Madras, now Chennai, in 1985, where we were looking at the similarities in foot problems seen in leprosy, la lepre, Hansen's disease, and diabetes. And he said, quoting patients with leprosy and also with diabetes, "Pain is God's greatest gift to mankind." And the problem is that those with a dense symmetrical polyneuropathy have lost the gift of pain. So the consequences of diabetic neuropathy are multiple. This is just the chronic sensory motor neuropathy. I haven't got time to discuss autonomic neuropathies. If you wish, we can discuss that in the workshop later on. It's true today, if you know diabetes, you know all of medicine, because diabetes encompasses all of medicine. The clinical consequence is at one end of this spectrum, you've got people who've got a very painful neuropathy, who can't sleep at night, allodynia, which is when a non-noxious stimulus gives rise to a painful experience. The pain's worse at night, it's burning, difficult to describe. At the other end of the spectrum on the right, you've got patients who've got loss of the gift of pain. They're at risk of foot ulcers. Most people have some symptoms and some signs, and the signs can only be detected if you examine the feet with shoes and socks removed. So how do we assess for neuropathy? Well, the first thing I can say is that you do not need any expensive equipment. The most important thing is to look at the feet with the shoes and socks removed. We can use simple tests. Can you feel the pressure of a monofilament? Can you feel vibrating 128 Hertz tuning fork, pinprick, ankle reflexes? We don't need quantitative sensory testing or electrophysiology, a complete waste of money. And Paul Brand again said you do not need any expensive equipment to diagnose the at-risk foot. Now, we showed in papers more than 35 years ago a clinical sign of diabetic neuropathy is these distended, and I can't point, dorsal foot veins. It would be nice to have a pointer tomorrow that works, by the way. Distended dorsal foot veins, you can see there. That's a sign of peripheral sympathetic autonomic neuropathy due to release of vasoconstriction. And we showed you get arteriovenous shunting. So this clinical sign we described in 1983, I think, if I remember. And the year before, I published a paper in the January edition of Diabetologia, showing that if you take blood from these distended dorsal foot veins, it's arterialized because of arteriovenous shunting. And this is the paper. The neuropathic diabetic foot is warm because of increased blood flow if there's no vascular disease. Dilated foot veins are a sign, and venous PO2 is elevated in those with a history of foot ulcers, compatible with arteriovenous shunting. In the same issue, a few pages after my article, was another paper by Mike Edmonds, my good friend from King's College Hospital in London. And this really was symbiotic. It added to what we showed, and he showed that using non-invasive Doppler studies that the results of pulse wave velocity, pulsatility index, was compatible with arteriovenous shunting. So, the warm but insensate foot is truly the at-risk foot in patients with diabetes, particularly in this region. In the UK now, we're seeing more neuroischemic ulcers. Because of our mass screening, and then primary care physicians get reimbursed if they screen the feet, we're not seeing so many purely neuropathic ulcers. There are easier tests. The Ipswich touch test couldn't be any easier. This is the Ipswich touch test. Can you feel the touch of a finger on the toes? Couldn't be more simple than that. Without pushing. And this can be used, and most of our nurses have 5 fingers on each hand, so they can do that test very easily. And this is just as good as the monofilament in this paper published in Diabetes Care by my friend Jerry Raymond from Ipswich. So he showed that the Ipswich touch test and the monofilament are almost in perfect agreement. And the health authorities love this test because it doesn't cost anything. It's free. Then there's the VibraTip. I have one here in my hand. It's a very simple tool. It's a pocket-sized, wipe-clean, battery-operated disposable device for checking vibration. Here it is. And here it is in the hand, so you can see. On the left-hand end, in here, there's a small battery. You squeeze this, and it causes the vibration at the tip. And the good thing about this, it's forced choice methodology. The patient cannot tell if it's vibrating or not by looking at it. And they can't hear it like you can hear a tuning fork. And in a study we published a few years ago, we showed in a study of 80 patients that the correlation was excellent between the other standard tests, including the Ipswich test and neuropathy disability score and the gold standard of biaesthesiometry or vibration perception threshold using quantitative sensory testing. So in my early research working with Professor John Ward in Sheffield, and later we had a gate laboratory in Manchester, we showed the importance of increased pressures and loads under the neuropathic foot in diabetes. High foot pressures predict ulcers, they're a risk factor, and we showed in a number of studies that these high foot pressures in the insensitive foot, because of repetitive pressure, leads to callous, hard skin, which acts as a foreign body and causes ulceration. But more recently, working with my friend and colleague, Professor Neil Reeves, Manchester Metropolitan University, they have a gait laboratory where you can assess gait not only walking, but going up and down stairs. Now, if you think about it, most trips and falls occur when you're climbing or coming down stairs, usually descending. And these may contribute, because of repetitive stresses, to the genesis of the Charcot foot in neuropathy. So we've done a number of studies where we can, using a camera system, there's Professor Reeves, tagged up with reflective markers, so we can look at gait, not only walking along the level, but up and down stairs. And I'll quickly go through these. This is kinematic and kinematic data, looking at walking and ascending stairs. The role of muscle power development, or torque development, peripheral neuropathy with sensory loss, there's a delayed neuromuscular response. And what we showed here, that if you look at the knee is in blue, the ankle is in red. On the right of each panel is the neuropathic diabetic patient, and on the left is going upstairs, on the right is coming downstairs. And you can see there is delay in every case in the role of joint torque development in patients with diabetes. Then we said, how accurate are people walking? Altered visual gaze behavior. They're slower to acquire the target and they're less accurate. And then we looked at balance. Now, the best way to show you balance is to show you a movie. And this was published a couple of years ago, looking at the center of mass minus the center of pressure. And the more unstable you are, the wider that'll be. So here on the left is a non-diabetic individual coming down the stairs. And on the right, you see a patient with neuropathy. Look at the sway. Look, these are unstable, slower gait. They're more prone to fall. And we were able to quantify this and publish these data. We looked at the metabolic cost of walking using VO2. Perception of difficulty, slower walking speed, and this has influence on physical activity. And again, we showed the diabetic neuropathy on the left of each column. Again, metabolic cost for walking is higher. So to summarize, mechanisms underpinning falls in diabetes is the rate of muscle force development, visual gaze, and balance. It's a higher metabolic course for those with neuropathy. The Achilles tendon may be tight, that may affect it as well, and this with muscular impairments due to a motor neuropathy, a sensory motor neuropathy, contributes to the common trips, falls, and even foot ulcer development. So this is the pathway, a simplified pathway, to neuropathic foot ulcer. The top, you've got diabetes, somatic sensory neuropathy, somatic motor neuropathy, and autonomic neuropathy. And this leads to decreased pain, as I've said, deformities, increase in foot pressure, small muscle wasting. On the autonomic side, decreased sweating, dry skin, prone to develop hard skin, callus. And this can lead to foot ulcers. the at-risk neuropathic foot and foot ulcers. In green is what the patient can do about it. On the left, can they reduce what they're suffering because of the loss of the gift of pain? They can by examining the feet, wearing sensible shoes, bottom left. Not doing your own foot care at home with a scalpel, as some patients like to do. I saw a case yesterday. A patient had developed a blister, so he got a dirty pair of scissors and stuck it into it. And just walked into the clinic yesterday morning in Manchester. Entirely preventable. On the right, you can moisturize the feet, have regular podiatry, and of course, if you've got an ulcer, it's important that you follow the advice to wear some offloading device. A junior doctor said to me, that patient's so stupid. Look, they've got a huge neuropathic foot ulcer and they're walking on it. I said, no, the patient is not stupid, you're stupid, because you don't know what it is not to feel pain. We limp when it hurts because it hurts, to offload the painful area to reduce inflammation. These patients continue walking on it and they feel great. So you have to remember the loss of the gift of pain. Now, in terms of education, H.G. Wells wrote these words. He said that human history becomes more and more a race between education and catastrophe. And we see the catastrophe in the diabetic foot clinic of education failing. So can I prove to you that education alone reduces the incidence of foot ulcers? Sadly, I cannot. I can't prove it. Here is a systematic review from the Netherlands, from Utrecht, of primary prevention of foot ulcers, and it shows that there is insufficient robust evidence to support education alone in the reduction of the incidence of foot ulcers. Too few trials, poor design, insufficient follow-up. But we must interpret this as lack of evidence, not evidence of no effect. I'm sure that education does have a place, I'm 100% sure, but I can't prove it to you. That's what I'm saying. And here's another population base for primary prevention. Again, a systematic review from London. Again, interpret as lack of evidence, not evidence of no effect. We can't prove it. What about the team approach? Well, again, Jerry Raymond's group in Ipswich have showed that in an 11-year prospective study where they introduced a multidisciplinary team approach with podiatry, regular foot checks, education, good shoes, and so on. And they were able to show a 70% reduction in amputation in their region. I can't prove it's education alone, but the combined effect of the team approach does work, and there are other data to support that. If you've had an ulcer, what about secondary prevention? These data from my friends in Nottingham, and they took patients with newly healed foot ulcers and randomized them to a usual care group or intensified education by general practice. So the intensified education had a group session showing them what to do, how to prevent recurrent ulcers. Although there was better reported foot care in the intensified group, they couldn't show a reduction in amputation or recurrent foot ulcers. Now, I believe that these patients, education alone does not work because they're too physically impaired. So you need some intervention the patient can perform, and one comes from the original observation again of Dr. Paul Brand. And he showed that before a foot breaks down, now on the right you can see those heels have probably been lying on an orthopedic surgical ward and the nurse didn't realize they had diabetic neuropathy and they haven't turned them. That's about to break down. What he showed is that before the foot breaks down, it warms up. Inflammation. So, could we stop nerve damage plus mechanical stress, the foot warms up? Is this a sign of about to ulcerate? So can we intervene there? So this was a study done by a good friend Larry Lavery from Dallas, NIH sponsored, and he had patients either have the structured care was the green line, the standard therapy was the structured care is the purple line, the standard of care was the green line. Standard of care was good. These are patients who had a history of foot ulcers. They were randomized to one of three groups. Standard of care, podiatry every 2 months, good footwear, regular podiatry. Enhanced care, the purple line, they had all that, plus they were given a mirror on a stick and a notebook, and they checked their feet each day because patients in Texas tend to be rather large. They might not be able to see their own feet. So they have a mirror so they can examine their feet on a stick, and if they found something worrying, they were told to contact their podiatrist. The group in the red, the top line, They were given a self-temperature monitoring, a little thermometer. They checked the skin temperature on both feet twice a day. If one foot was warmer than the other by 1.5 degrees Celsius, they were told to rest and see their podiatrist. Now that's education plus an intervention. The patient felt one foot was warming up before it breaks down. They didn't walk, and it reduced ulcers by 30%. So there is a possibility. What about treatment? Well, first of all, we need to classify. There are many classification systems. One is the Wagner system, which is tried and tested for many years, from the superficial grade 1, deeper grade 2, grade 3 probes to bone with osteomyelitis, grade 4 is localized gangrene, grade 5 in the middle, bottom is gangrene whole foot. And on top of that, we've got the University of Texas and many other systems. Now, I think a diabetic foot will heal if you let it. I don't think I know. A diabetic foot will heal if you let it. If there's good arterial inflow, we're getting much better at distal bypass surgery. If any infection is appropriately managed, we're getting good with multiple antibiotic therapy, intravenous perhaps. And you remove pressure from the margin and the ulcer itself. We're least good at that because we cannot conceive that someone would walk on a foot ulcer. Now, this is a lady that came to see my nurses many years ago, and she didn't come to see the nurses because of this nasty lesion on her foot. She came to see the nurses in the early days of blood glucose monitoring. My blood sugars are high. So the nurse appropriately altered the insulin. Then before she left, she said, "Oh, you better look at this spot on my foot." The spot on the foot was due to a rusty nail having gone through the third metatarsal head region. She had osteomyelitis in the proximal part of the proximal phalanx. She had an interphalangeal third MTP joint septic arthritis, and she had involvement of the distal third metatarsal. The key question here for management, she's got infection, we treat that aggressively, intravenous antibiotics. We control the diabetes, intravenous insulin. The key question here is the circulation. She had an excellent pulse, normal Dopplers. So we can get away with local surgery. Now, there is increasing evidence, as we can discuss if you wish this afternoon, that local osteomyelitis in one bone or two in the foot can be treated by antibiotics alone. But usually if you've got a septic arthritis, you need some form of surgery. And it was Dr. Robin Lawrence, who founded the British Diabetic Association, who originally had type 1 diabetes, one of the first people in England to receive insulin, that saw a case like this during the Blitz in the Second World War. And there was no consultant around, so he told the surgeon, he drew a cake. He said, "Cut a slice out of the cake." And that's cutting a slice out of the cake. Now, you'd think this is awful. It's not going to heal up. Well, that's a few weeks later. The diabetic foot will heal if you let it. Intravenous antibiotics, take away the infected part, and don't walk on it. And it healed up. This is the kind of foot I show to a medical student, and they don't see that there's a toe missing, because it closes up. So you can heal the diabetic foot. But there are many problems in clinical trial design that have led to many of the newer therapies really having failed in clinical trials because of the people that did the studies did not take into account of confounding variables. Most important of all is offloading. A classic study when I was working in Miami in 2002 appeared in the American Journal of Surgery for Promogran, which I think is probably quite good. But the study showed it was just as good as saline gauze, which cost about 1/50th of the price. And they said offloading was left to the individual. That means they didn't do any offloading. Activity. Can you compare someone like you, who is sitting here all day, with someone who's working as a conductor on a train, walking up and down all day? Can you have those in the same trial? How much day do you spend walking, sitting, standing, etc.? Weight, BMI, footwear, adherence, climate. Can we have a controlled trial looking at new therapies for diabetic foot ulcers with a batch of patients in Cairo and another batch of patients in Helsinki? Maybe plus 30 here and minus 30 there. All these things we need to think about. What about dressings? Dressings do not heal ulcers. They give false reassurance into the covering an ulcer they were healing it. Not true. A dressing is really not helpful in healing ulcers, it's just to keep the wound clean. There is no evidence to support the use of any particular dressing, and here's my friend William Jeffcoat, who did this randomized controlled trial of 3 dressings. NA is not adherent, Inidine and Aquacel. Well-designed study that you could find no difference in outcomes despite the dressing being used. The only difference was one dressing was 3 times as much as another. Here's a systematic review published in 2012. Evidence of poor quality. More expensive dressings do not offer any obvious advantages. What about negative pressure wound therapy or vacuum-assisted closure? Now, this was developed in the United States 20, 30 years ago and leads to wound contraction, neoepithelialization, and it removes gunk or exudate, infectious materials. There are 2 randomized controlled trials, not perfect, there are problems with these trials, but there at least is some evidence that negative pressure wound therapy helps. This was a multi-center trial in the USA, published in The Lancet 2005, where they randomized patients with local surgical treatment to a VAC or standard of care. And they showed more rapid appearance of granulation and rapid healing in the VAC control group. A later study published again in less complex foot ulcers, those who didn't respond to standard of care, offloading, antibiotics, etc., they showed that those who had negative pressure wound therapy were more likely to heal and there were less amputations. So some evidence. This is the old VAC used in those studies. You have a seal around the wound, a sponge, and you apply a negative pressure of 130, 120 millimeters of mercury for 23 hours a day, and it removes all the exudate and it stimulates granulation tissue in this first ray amputation, and you can see the result after a few weeks of VAC. If anything, hypergranulation. So this is a useful non-invasive therapy when used appropriately. And you don't need it in the routine neuropathic foot ulcer. What you need to do there is offload, and I can talk about offloading in the workshop if you wish, because we've shown that it works if you actually wear the offloading device. And then a series of studies from my Miami group. And what about hyperbaric oxygen? Who uses hyperbaric oxygen here? Anybody? Well, that's reassuring because it's useless. Anyway, here's some studies. Look at the rapid growth of hyperbaric oxygen in the United States. More than 1,000 chambers today. More than 1,000 chambers. So it must work because it's reimbursed. Well, we know hyperbaric oxygen leads to local vasoconstriction. It's good for edema, increased fibroblast proliferation, angiogenesis stimulation, leukocyte killing, recruitment, and synergizes with some antibiotics. But it's been used to treat almost everything under the sun or under the clouds. And leprosy, it must be a good antibiotic. And this is just a small list. And of course included there are diabetic foot wounds. So where's the evidence? Well, most of the studies of hyperbaric were originally used case series, case reports, and cohort studies, but I would suggest to you they're useless. What we want in the diabetic foot is no longer, I've done 6 cases and it works. We want, here is the evidence, so randomized controlled trials. Now, I'm a senior associate editor, have been for heaven knows how many, 16 years, for diabetes care. And this study came our way in 2010 from Magnus Londahl, who I know. And this was a good study, well designed, from Sweden, a placebo-controlled, double-blinded, randomized controlled trial of chronic neuroischemic ulcers. 5 treatments per week, up to 40 sessions, or dives. And they showed complete healing was more likely in those who received hyperbaric oxygen. It may therefore be an adjunctive useful therapy in those who've got neuroischemic wounds that can't be revascularized and are not getting better. So it's a very small group. But for some reason, the change wasn't seen until 9 or 12 months after the treatment. But we accepted this paper, well designed and published, and I got I took an editorial to go with it. But then Dave Margolis, who's an epidemiological dermatologist from Philadelphia, he looked at the efficacy of hyperbaric oxygen for diabetic foot in a huge wound care network of 6,259 patients. And what he showed in this study was that hyperbaric oxygen patients were actually less likely to heal and more likely to undergo amputation. Even accounting for confounding variables, they're evidence. And then the Canadians thought, well, let's try and replicate. These are hyperbaric oxygen experts from Canada. Let's try and replicate the study from Sweden. And they did a multi-center randomized controlled trials on a good number of patients, chronic diabetic foot ulcers, 30 daily 90-minute dives or treatments with hyperbaric oxygen or hyperbaric air. And they couldn't show any difference whatsoever, and this was published in Diabetes Care last year. No difference in any outcome. Hyperbaric oxygen did not reduce major amputations requirements as compared to best practice. No difference in healing rates or the number of healed wounds. No difference in quality of life. No evidence. So what's wrong with hyperbaric oxygen for diabetic foot wounds? Quackery. Sounds good. Possibly. Evidence of efficacy? Minimal. Effectiveness? Little to none. Resource allocation? More bangs for your buck or your Egyptian pound elsewhere. So then we thought the Dutch might give us the answer. And this was a study, this was the publication in the Journal of Diabetes in 2015, telling them about this trial, the Damocles, the sword of Damocles, hanging over the leg. They called it the Damocles study, and it's the largest ever study, run in the Netherlands, and they took ischemic ulcers, and the results, they said, would be ready in 2005. The results were just published a few weeks ago. Completely negative. Damocles study, oops, it's negative. It was presented at the VEITH Symposium in New York last November. Hyperbaric oxygen did not significantly improve wound healing or limb salvage in diabetic ischemic wounds. So I'd caution you, it's very expensive, and I am a cynic. So I said to the people at hyperbaric, actually, hyperbaric oxygen is probably a very good way of offloading the foot because you can't walk around inside the chamber. But it's rather expensive. So I think, talking to the future, we need proper guidelines on clinical trials. What should be the endpoint? Should it be percent healing at 6 weeks, 12 weeks? Should it be total healing? Granulation? What's the standard of care? Should it be in the control group? We need proper design of clinical trials. What's the length of follow-up? Londal study, 9-12 months. Inclusion-exclusion criteria need to be standardized, stratification, footwear, and so on. There are dangers of prophesying. Here people who have not done so well. Radio has no future, somebody said in the 1930s. X-rays will prove to be a hoax. There is no future for guitar bands, said Decca Records in 1961. I think there may be a world market for 5 computers, said Thomas Watson, 1943, chair of IBM, and yet there are probably more than 5 computers in the front row. So there are dangers of prophesying. But I think the future, we've had lots of systematic reviews and Cochrane analyses. I think these really need to be done not by people who are looking for an extra publication, but people who actually know the field. And many of these systematic reviews are done by people, looking for something to do. Randomized control trials must use expert centers, not ones who want $5,000 per patient and will enroll as many as you want. Agreed standards of care for the control arms of studies, agreed endpoints, internationally agreed guidelines on the design of trials. And this may be through the International Working Group on the Diabetic Foot Study Group, the ADA Council, and so on, working together to come forward. But until then, we need to work together as a team, because each of the members of this team may think that someone else is looking after the foot when actually nobody is. And this is in order of alphabet. The diabetologist is probably the least important in the team. Most important, I would suggest to you, is the patient, the nurse, the podiatrist, and the shoe fitter. So I'll leave you with this quotation from Professor John Lindsay, who was professor of medicine at the University of Belfast 100 years ago, and his medical students had to learn all his aphorisms. And in terms of the diabetic foot, he's absolutely right. For one mistake made for not knowing, 10 mistakes are made for not looking. And most diabetic feet, you can identify the high-risk foot, removing the shoes and socks, and looking at the feet. Shukran. We're going to have a workshop anyway, so we can discuss that.
This was a very, very elegant talk, Professor. The quality of your slides are perfect. We really enjoyed it. We have 2 suggestions now, okay? Either we take one question or two questions for each speaker, or we postpone it all for the workshops? What do you suggest? Is it lunch or questions? Would you like to ask questions and get delayed for another 15 minutes, or go to lunch? Thank you very much for this session.